So today's class will be on CTG. This will be a part in your ops table viva. It will carry 10 marks. ठीक है sir? What is CTG? बोलो. This is a discussion. हाँ. Cardio? Cardiotocograph. So cardio is heart. We will measure the fetal heart rate. Toco. What is toco? Toco means contraction. We will measure the fetal heart rate with the uterine contraction in the labor. So cardiotocography. See, initially what they didn't know how to measure the fetal heart rate. Fetal heart rate they can measure using a stethoscope or fetoscope or something like that. How will they measure the uterine contraction? What they did was they used to place a bulb inside the uterus and connect it to a mercury manometer. Have you seen mercury manometer? Sorry, the sphygma manometer, in which mercury will be there. It has till 200. I think some of you might have seen. So they used 5 big apparatus as such. Okay. And then when the contraction is started, they thought initially it will be till 20 millimeters, but it reached to 80 to 250 millimeters, the contraction. Okay. And the fetal monitoring, there is direct fetal monitoring and indirect fetal monitoring. Direct fetal monitoring, what they do, they attach a, see, this is an electrode. Okay, this is fetus head. Okay, there the electrode is directly attached to the fetal head. From the fetal head, this electrode it copies the P, this is QRST, fetal cardiac parameters. This takes it and it gives us the interpretation. Okay, this is direct electronic fetal monitoring. Usually we don't do this. What we do is indirect electronic monitoring. In indirect monitoring, what we do, we use Doppler principle. We had the Doppler class last time. What is Doppler effect? What does it do? What is the mechanism of Doppler? Normal ultrasound key concept. What does it happen? How? What happens actually? Where sound waves are produced, sound waves will go and hit the target and then it gets reflected back. That reflected image, it is gathered and it is interpreted. Same way in indirect monitoring, what we have, the CTG, traditional CTG we use, it has indirect monitoring only. We have a tocometer, cardiotocometer, okay, that we place on the maternal abdomen, fundus. Pete amra attach kore rekhe debo. That will receive. It will hit the uterus and receive back the signals and it will interpret. See, this is the CTG machine. This is the CTG strip. It has 2 columns. This column is for uterine contraction. This column is for heart rate. So as I told, it is a technique to record fetal heartbeat and the uterine contraction during the intranatal period. How do? We have 2 separate transducers. One transducer for record the fetal heartbeat and one transducer for measuring the contraction. One transducer we will record the fetal heart rate. We will position where we can hear the fetal heart rate. It is mostly on the midpoint of left spino-umbilical line. There we try to position it and we will hear the fetal heartbeat. Then we will tie it. And then on the fundus to record the uterine contraction. How will you interpret a CTG? See, this is a big class and it is a new topic for you. It will be difficult for you to understand. Today we will do half class. Next half we will do on the next class. You remember this Dr. C BRAVADO. Dr. C BRAVADO. When they give a CTG for you, what will you do? First, you will define risk. You will see the contractions. You will see the baseline rate. Then variability, acceleration, deceleration, and finally you will tell the overall impression. You will define risk. Then you will see the contraction, baseline rate, variability, acceleration, deceleration, and overall impression. So define risk. When should we do a CTG? CTG is not necessary for every patient getting admitted. Okay, অনেক patient admit হয়, but সব patient এর CTG দরকার পড়ে না. In cases like if there is any heart disease, if there is hypertensive disease, or if there is asthma, cystic fibrosis, if there are hemoglobinopathies, VT, DVT, thrombocytopenia, why in these diseases we are monitoring? Why CTG is required? This will directly affect the baby also. Yes, and labor is a stressful period, and we should see if mother is able to tolerate that. When every time in cardiac disease, for example, when uterus contracts, no, uterus এর কিছু একটা blood থাকবে ভিতরে. When uterus contracts, the blood will get pumped back to the heart. So the overload is increasing, cardiac overload is increasing, and if this heart is not able to pump the blood properly, that will affect the baby also. So baby's heart rate might differ. See, also in this hyperthyroidism, if there is any hepatitis, HIV, TORS disease, SLE, scleroderma, if there are any kidney diseases, epilepsy, liver diseases, okay, this you should know. See, if maternal pulse, if it is more than 120, 2 readings on 30 minutes apart. If the BP is more than 160, 110 on a single reading, or if BP is more than 140, 90 on 2 consecutive recordings. This is the criteria for hypertension, severe preeclampsia and preeclampsia. Severe preeclampsia means BP more than 160, 110. Preeclampsia, there is more than 140 or 90 on 2 occasions with proteinuria. Okay. And if there is any meconium stain liquor, if meconium stain liquor is passed, but vaginal leaking is there, if it is greenish colored, we try to do a CTG. So BR is done, BR, Dr. C BRAVADO, doctor is done, then C for contraction. See, this is the uterine contraction, this is fetal heart rate. Okay, this upper part, then this is lower part. See here, this is this y-axis, no, this is representing the fetal heart rate. See, from 60, 80, 110, 120, 100, it is there. This is heart rate, this is time, x is time. The normal fetal heart rate is between 110 to 160. So we should see if it is between 110 to 160. See, it is between 110 to 160. This I will tell you later also. Now come to the contractions. Okay, see, this is the frequency of contraction, 40, 60, 80, 100 pressure. This is the time interval. This one small box, no, there are this is 2 box, this is 1 box, this 1 box is 30 seconds. So this combined is 1 minute. The CTG paper runs at a speed of 1 centimeter per minute. So in 1 minute, this from here to here, it will get done. It will get recorded. See this peak, this one. These are uterine contractions. Normal contractions, see, for 10 minutes, no, it should be less than 5 contractions. 10 minutes, when I see from here, this is 1, 2, 3, 4, 5 big box, 6, 7, 8, 9, 10. From here to here, there are only 2 contractions. If there are more than 5 contractions, it will be abnormal. Why more contractions are abnormal? Yes, every time when there is uterine contraction, blood supply to the fetus is hampered. Ekta contraction hocche, when the uterus is in contractile period, blood supply to the fetus will be cut off. When uterus gets relaxed, at that time fetus will get the blood supply. So if there is more contraction, there is chances of fetal hypoxia. So if it is less than 5 contractions, normally it should be less than 5 contractions. If it is more than 5 contractions in 10 minutes, we call it tachysystole. If the contraction is lasting more than 60 seconds, we call it hypertonus. See here, the contraction is lasting for approximately how much? 1 minute. Yes, from here to here it is 1 minute. This is x. সবাই ভালো করে দেখে নিস। I'll ask questions. From here to here it is 1 minute. Yes, so the contraction is lasting for 1 minute. If the contraction is lasting more than 60 seconds, it is hypertonus. See here the contraction is lasting more than 1 minute. So there is a hypertonus here. So C is done. Next is BRA, baseline fetal heart rate. I told you the baseline fetal heart rate is from 110 to 160. Sorry, the normal fetal heart rate is 110 to 160. How will you calculate the baseline? Very easy. See, you should try to draw a line. See, if I try to draw a line here, see, it will be like this. It should touch all the trough here. This is trough, this is the peak. See, all the trough, no, if I try to draw a line like this, it will be like this. So baseline is approximately 150. It is the mean of heart rate. Yes, baseline is approximately 140. So this is the mean fetal heart rate rounded to increments of 5 beats per minute during 10 segment. Normally you remember, just you take a baseline, you draw a line. You draw a line and that approximate mean what you get, that will be the basal heart rate. If that peak is here, okay, and if you draw a line, it will be 160. Baseline will be 160. What are the causes for, sorry, this is bradycardia, causes for bradycardia, and this is tachycardia. If heart rate is less than 110, we call it bradycardia. If it is more than 160, we call it tachycardia. When heart rate is less than 110, if there is any congenital heart block, if there is hypothermia, if mother is under general anesthesia, if she is under any benzodiazepines. When fetal heart rate is more than 160, if she is having any fever, if there is any fetal infection, or if there is any, if mother is in a state of stress or anxiety, if she is in atropine or terbutaline. So there are 3 categories for measuring the heart rate. You can say if the heart rate is reassuring, non-reassuring, or abnormal. Okay, if 110 to 160, what is that is the normal fetal heart rate. Yes, if it is that, we call it reassuring. If between less than 100 and more than 180, it is abnormal. Between this, we call it non-reassuring. So 100 to 109 or 161 to 180 BPM. You just remember reassuring and abnormal. Non-reassuring is in between that. Baseline variability, it is very important. Okay, see, baseline variability matlab, see, this every peak, no, this small peak, that is a contraction rate. See, this peak, every peak increase in heart rate is because of the sympathetic activity. And every time when the heart rate drops, this trough, that is because of the parasympathetic activity. So this both should function together. Sympathetic activity, what it does, it will try to increase the heart rate. Parasympathetic will try to decrease the heart rate. So both should be synchronous to make the fetal heart function properly. Normal variability is 5 to 25 beats per minute in a period of 10 minutes. See, if you don't understand, I'll explain again. Okay, see, for in this 1 minute, okay, there should be increased in 5 to 25 beats. That is called variability. There should be increase in 5 to 25 beats. Sorry. See, from here, this is a 1 minute interval. Okay, so see, here heart rate is 130, here heart rate is 170. Okay, here heart rate is 140. So from 130, it has increased to 140. So there is 10. So variability is approximately between 5 to 25 beats. From again, it has decreased here. Then again, it has increased. Variability means it is constantly changing. It should be 5 to 25, between 5 to 25. Amplitude of Dada, continue. Amplitude of peak to the trough in beats per minute. So it is regulated by autonomic nervous system. There is push and pull. When there is peak, that is because of sympathetic system. When there is trough, that is because of parasympathetic system. So there is a pull and push. This produces beat to beat oscillations. Okay. If there is no variability, if there is a straight line, that is abnormal. There should not be a straight line. For a slide, next. See, there is no variability at all in first. The second one, there is minimal variability. Third, there is moderate variability. In the first CTG I showed, there was good variability. So if it is 0 to 5, minimal variability, 6 to 25, normal, more than 25, salutary. Salutary, it is abnormal. Next. Correct. Next. See, increased variability when there is more sympathetic system activation. When fetal breathing is more, fetal activity is more, if there is any narcotics, barbiturates, steroids, these things that will increase the sympathetic system. Decreased variability when no variability it is there. When it both doesn't act, there is fetal acidemia, maternal acidemia. If Maxwell is given on fetal prematurity, there is decreased variability. Next. What is acceleration and what is deceleration? Acceleration, after deceleration you'll finish the class, okay? Acceleration is, there is increase in fetal heart rate more than 15 beats lasting for 15 seconds in 2 minutes. More than 15 beats for more than 15 seconds in 2 minutes. That is acceleration. Deceleration is exactly opposite. Lasting for drop in less than 15 beats per minute for 15 seconds for 2 minutes. It is deceleration. Drop. Acceleration is increasing. Next. So acceleration is seen in any fetal movement or stimulation, uterine stimulation. If you take any blood or if there is umbilical cord occlusion in this and all. Next. See, that is an acceleration. That pointer. That is an acceleration. Deceleration means baseline dige niche ekta dip asbe. I will show it the next slide. Here from the baseline, see the baseline here is how much? If you draw a line, where it is coming? If you draw a line, it will be on the 120. Yes, from 120, there is increase in 15, more than 15 beats has increased and it is lasting for more than 15 seconds. It is lasting for nearly 1 minute, that acceleration. So acceleration criteria is met. So it is lasting more than 15 beats. From 120 it has risen to 150. So more than 15 beats, more than 15 seconds in a period of 2 minutes. So this is an acceleration. Next. Deceleration I told, when there is a drop in 15 beats per minute lasting for more than 15 seconds. That is deceleration. This is not needed. Next. There are 3 types of deceleration: early deceleration, late deceleration and variable deceleration. Early, late, variable. See, this is the uterine contraction. This is acceleration. This is the baseline. From baseline it is increasing, we call it acceleration. From baseline, if it decreases, we call it deceleration. Yes? So this is the contraction. See, when deceleration occurs as a mirror image to the contraction, we call it early deceleration. See, it is a mirror image. This is the peak when it is onset. See, this and this are same. When uterus is contracting, there is a dip in fetal heart rate. You understand like that? Yes, when there is uterine contraction, fetal heart rate is decreasing. It is a mirror image. This occurs in head compression. When there is contraction, baby's head is down. Okay, so when there is contraction, baby is pushed down. The fetal head is getting compressed against the pelvic cavity. Yes, so contraction jogo nasti. Similarly, it is like a mirror image. This is also dropping. Fetal heart rate is also dropping. This is early deceleration. Late deceleration, what happens? This is late deceleration. So uterine contraction shuru hoega che, and when it is maximum, at that time fetal heart rate stops falling. This is late deceleration. You can see this in uteroplacental insufficiency. Compulsory, this is an 1 mark in NEET. From this 3 you will get one MCQ. Early deceleration you will see in head compression. This is this is physiological. This both are pathological. Late you will see uteroplacental insufficiency. Variable, there is contraction. Okay, but fetal heart rate, it doesn't depend on the contraction at all. It doesn't depend on the contraction. Anytime it will occur. That is variable. You see variable deceleration and cord compression. ठीक है sir? Understood? Next. See, from the onset to the nadir, it is more than 30 seconds, and it is a mirror image. When the contraction is occurring, simultaneously there is a dip in heart rate. We call it early deceleration. Next. See, this is an early deceleration. See, when there is a contraction, see, contraction is there, and simultaneously there is a dip. From the onset to the nadir, it is more than 30 seconds. So this is an early deceleration. Next. Late deceleration, it is because of uteroplacental insufficiency. You should know this. Next. See, there is the contraction. After the contraction, after the peak, there is a fall in fetal heart rate. See, there is a contraction here. After the contraction, there is a fall in heart rate. This is deceleration. Okay, sorry, this is late deceleration. Next is variable deceleration. As I told here, you should know it is seen in umbilical cord compression. That is an MCQ. Onset to next. See, there is a contraction. The nadir, it doesn't depend on the contraction only. It can happen anytime, and the onset is between the onset to nadir is less than 30 seconds. So this is variable deceleration. ঠিক আছে, অনেকটা deceleration আছে, but it doesn't depend on the contraction only. It can happen anytime. ওখানে একটা আছে, this is there. Next. ঠিক আছে, I think we can finish the class.